Perfect. Okay, can everyone hear me?
Yes, yes.
Okay, and then can you see my slides?
Yes.
Perfect. Okay, here we go. Today I'm going to start my series of going through the drug classes for HIV. So we are going to start back at the very beginning at the nucleoside reverse transcriptase inhibitors, which I think there's some appropriateness to this with it being World AIDS Day, right? We're going to start at the beginning, and then we'll go through the treatments options. So we're not going to talk necessarily about really full regimens or what to start somebody on, but we're going to talk about those first drugs and which ones we still use, and we'll talk a little bit about how we pair them as we go through. So some disclosures that really aren't relevant. I did serve on Gilead's advisory board last year, and then I was on Theratechnology's advisory board this year. Really shouldn't have any impact on anything I say today. But there we go. So we're going to go through the individual drugs in the NRTI class. We're going to discuss the current use of them. And then I'm going to review the adverse effects of the NRTIs utilized in clinical practice. And I want to emphasize that because the NRTIs have a lot of adverse effects as a class, and the ones used in clinical practice today are a lot cleaner than some of the older ones. So this is the viral life cycle of HIV and the virus entering the CD4 cell. So we're going to focus on the reverse transcriptase inhibitors, which stop the replication of RNA to human DNA. So that's where we're at in the life cycle. So from the NRTI timeline, in 1981, AIDS was discovered in the US. It's thought now, looking back in history and doing some other scientific studies, that it had been here either since the late 60s or the early 70s, but it was actually discovered as a disease in 1981. In 1987, we got our first drug, which was an NRTI, which was zidovudine, or commonly known as AZT. The 90s gave us a lot more of our nucleosides. So here we see didanosine, stavudine, all of which are no really longer used, lamivudine and abacavir. And then the 2000s gave us tenofovir, disoproxil, so TDF, as well as TAF 15 years later. And so we'll talk through some of those. In the late 90s into the early 2000s is when you start seeing these combination products. And now we're to the point where a lot of these are in our single tablet regimen. So if you look at a lot of the single tablet regimens that are available, you're going to have combinations of one of the forms of tenofovir, usually with emtricitabine. And we'll kind of talk through some of that. So that's where our timeline is. So our historic NRTIs that I'm not going to really talk about as much, really zidovudine, stavudine, and didanosine. If you read the DHHS guidelines, you'll notice the 3-letter abbreviations that are all throughout. I actually make my students read parts of the guidelines when they're here with me on rotation, and they absolutely hate this because what does AZT have to do with zidovudine anyway? And so it's a really hard learning curve, and a lot of providers no longer really use these 3-letter abbreviations. If you talk to some older HIV providers, they will. But the 3-letter abbreviations originally came from the original chemical structure name. So you get stavudine is D4T because its original chemical structure was something way more scientific than I'm going to go into right now. So you get those original names, and so you end up with these weird abbreviations that don't seem to make sense. Now, if you look at the more modern ones, like dolutegravir is DTG, and that makes sense. But just so you know, if you're reading or you read historical information, that's where the 3-letter abbreviations come from. I have a picture of the Dallas Buyers Club poster on here. It's a great movie about the early days, but one of the drugs featured in Dallas Buyers Club is AZT. So as you watch the movie and you see them giving patients IV medications and them discussing all the side effects of those medications, it was the early AZT studies and pushing out to patients that's being depicted there. So all 3 of these are very toxic. Pancreatitis, lactic acidosis, hepatomegaly, fat redistribution, and bone marrow suppression were all commonly seen. Bone marrow suppression was very common with zidovudine. And then fat redistribution with all three, this is where you would see that buffalo hump or the loss of the fat pads of the cheeks that a lot of patients struggled with. And then lactic acidosis, if you actually look on the package insert of any NRTI to this day, they will all say that lactic acidosis is a risk, which is theoretically true. However, you just don't see it with a modern nucleoside, but with these older nucleosides you did because of their toxicity profile. Of note, I'm not going to talk about it today, but zidovudine is still used postpartum and in the perinatal period for HIV prevention if the child is being born to an HIV positive mother. But that's really the only place that it's used in today's modern world. So these are guideline recommendations. Antiretroviral therapy for treatment-naive patient generally consists of 2 NRTIs, nucleoside reverse transcriptase, plus a combination with a third agent. And so the currently recommended NRTI combinations are going to be abacavir and lamivudine, TDF plus emtricitabine, or TAF plus emtricitabine. Now, could you combine these some different ways? Yes, you could, but these are the ones that are in combination products. And so those are the ones that are the easiest for patients to take. And that's one of the things that we want to look at when picking a regimen is side effects, what's best for the patient, but also what's easiest for them. Of note, though, with the FDA approval of Dovato, lamivudine has been approved as a solo NRTI when paired with dolutegravir. There's also some studies that show it pairs very well with darunavir boosted to give a 2-drug combination there. And so that is one place that you can use just 2 drugs if you're going off of the FDA guidelines. Okay, so talking about the combination products, so abacavir and lamivudine I'll talk about together. So this is the combination brand name product Epsicom and is available also as the backbone in the single tablet regimen Triumec, which is dolutegravir plus abacavir plus lamivudine. You have to be careful for hypersensitivity reactions when abacavir is employed. This is one that HLA B5701 testing is required because if the patient is HLA B5701 positive, they are more likely to have a hypersensitivity reaction, which can lead to death in the patient. And so you do need to get that testing before you start a patient on abacavir. If you, for some reason, don't get that test or you get it and somehow abacavir gets started anyway, and the patient does have an abacavir hypersensitivity reaction, that needs to be immediately stopped and you never re-challenge that patient because a re-challenge could result in a worse reaction. Cardiovascular risk with abacavir, this is again with abacavir. The data is conflicting of whether it causes increased cardiovascular risk, but the guidelines do recommend avoidance with high cardiovascular disease. And so if you look at some of the trials that have been done, the DAD cohort, et cetera, some studies say there's an increased risk for cardiovascular disease. Others conflict that and say there isn't. But I do think it is a reason to be cautious, especially if you have somebody with underlying cardiovascular disease or someone underlying at risk for cardiovascular disease. And I think it'll be really interesting as the years go on to see how much abacavir continues to be in play as HIV treatment moves to this 2-drug regimen thought. And with TAF now having the availability to give tenofovir without some of the renal toxicities, it'll be interesting to see how much abacavir plays in to our future regimens that we use. But if you're using abacavir, hypersensitivity reaction, cardiovascular are some of the biggest things you need to know. The third agent may impact utility, and I really say this more from an historical point of view. So you wouldn't necessarily want to use abacavir lamivudine with efavirenz or atazanavir boosted as a first-line regimen because if you have somebody with a baseline viral load over 100,000, you can actually end up seeing virologic failure. The same can be true of darunavir and raltegravir when combined with abacavir and lamivudine. So just be cautious. Those are guidelines. Again, a lot of those regimens, I mean, they're probably going to use TAF and tricitabine in anyway, and I've been trying to avoid efavirenz for the last 5 years anyway, so please don't start that on your naive patients. So moving on to tenofovir disoproxil and tricitabine, and then I have next slide on tenofovir alafenamide as well. So tenofovir disoproxil is our brand name Truvada. So if you're in brand names, this is Truvada. It's also the backbone nucleosides in the single tablet regimens, Atripla, Complera, and Stribild. So Atripla is efavirenz plus TDF and tricitabine. Complera is rilpivirine, and then Stribild is elvitegravir plus TDF and tricitabine. The great news about tenofovir disoproxil and emtricitabine, as well as TAF emtricitabine, is it has activity against hepatitis B in both drugs, which is important because if you're treating hepatitis B, you need both drugs to be active in an HIV positive patient for hepatitis B. Really, one of the places where TDF kind of fell out of favor, especially as TAF was developed, is it could lead to worsening renal dysfunction. So you have to dose adjust it under a creatinine clearance of 50, and you want to avoid it if their pre-existing renal dysfunction is creatinine clearance is below 60. My rule of thumb when we were using a lot of TDF, FTC, as my pharmacy students always calculate creatinine clearance. And my rule of thumb is if somebody was on TDF and their creatinine clearance was less than 60, we needed to be looking at other options. We may not need to necessarily change anything that day, but it was a, hey, we need to put a bug in the patient's ear. Maybe we need to look at different options, etc. And remember, when it comes to changing patients on their meds, a lot of patients, especially older patients, are very cautious about changing. So, you know, if you want to change, I think mentioning it earlier is always a good idea, just to give them time to let that sink in. The other problem with tenofovir disoproxil is it does have decreased bone mineral density. All antiretroviral therapies can decrease bone mineral density, but we know that TDF does it worse than any of the others. And so if the patient has osteoporosis or osteopenia, you need to be cautious. And then this can cause osteoporosis. And we've seen cases of avascular necrosis as well. And so this is one of those places that if the patient has been on TDF, and they are indicated for a DEXA, they do definitely need that DEXA. And then TDF, FTC, tenofovir, and emtricitabine is FDA approved for the use of PrEP in both men, women, and IV drug users. And so we have a whole lecture on PrEP, but just remember that it's also appropriate to use there. So TAF emtricitabine is combination brand name Descovy. So this is his single tablet combinations is Odefsey, Genvoya, and Biktarvy are some examples of single tablet regimens. So very similar to TDF and tricitabine. Again, both have activity against hepatitis B, but TAF and tricitabine has a better renal and bone profile than TDF and tricitabine. Here your creatinine clearance is less than 30 by the FDA, but I've read some studies of them using TAF and emtricitabine in hemodialysis patients, and it looks promising. Again, not FDA indicated, so I'm not saying you should do that, but there is data that's being looked at for that. And so I think it gives me confidence in its safety abilities. And then the couple of things to think about with TAF and tricitabine, particularly different than TDF, are you can see lipid increases compared to TDF. And we think this is because TDF is lipoprotective in the sense that it pushes the lipids intracellular. Doesn't seem to have clinical significance that we know of at this time. But if you do see a change in their lipid profile, that's probably why. The other thing that is not on the slide to think about is weight gain. There's been a lot of data in the last year or two implicating the integrase inhibitors in weight gain, but also TAF associated with that. And so the data is having a little bit more of a challenge parsing out, well, is it the integrase inhibitor? Is it TAF? Is it both together? What's the cause of the weight gain? So if you have somebody on TAF, and they're complaining of increased weight gain and you're seeing that in your clinic, you may want to be mindful of that, and they may need to come off of TAF in those instances. Drug interactions are not equal with Truvada. They're very similar, but you have a slightly different P-glycoprotein pathway with TAF and tricitabine. So utilize your good drug interaction resources or your friendly pharmacist to look for drug interactions. So this just summarizes what all the combination products are if you're looking at the individual drugs as we're playing alphabet soup here. Again, remember lamivudine by itself is in combination with dolutegravir, Dovato. The others are all 3-drug single tablet regimens. So just as a summary, NRTIs are historical backbone of our initial treatment naive regimens. Is this going to change as 2 drugs become more popular and more widely accepted? Probably, but only time will tell. Remember, if you're using a bacavir, you do need to get baseline HLA B5701 testing to make sure the patient's not going to be at risk for hypersensitivity reaction. TAF is safer from a bone and renal toxicity than TDF perspective. However, keep in mind that you need to watch their lipids and you need to watch their weight. Again, clinical significance being questionable. And then keep in mind, again, we'll have a whole lecture on hepatitis B, but if you're treating hepatitis B, tenofovir and tricitabine is going to be your preferred NRTI combination of choice. So with that, I will take any questions.